Hello, everyone. Welcome to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I'm a filmmaker and writer. I've been working with CCF for 10 years, folks, 10 years. That's a decade if you didn't know. Creating different kinds of video content, live video series like this, produced videos, patient-centric videos, treatment-centric videos, all with the same mission in mind, and that is to raise awareness and to educate people about neuroendocrine tumors. Now, if you're familiar with the show or a fan of the show or a regular at the show, you know that, hey, today is not Thursday, which is typically when we do things, but today we're doing the show on Friday. And so if you're joining us, we appreciate you being here. Let us know where you are signing on from in the world. We always like to see how far these programs reach. I see people already doing that. Effie, I see your donation. Awesome. Starting off great today. Before we get started, we always want to thank Ipsen Biopharmaceuticals for their support of Luncheon with the Experts. We couldn't do this program without them. And we always have this disclaimer at the top of the program from them, which is the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so like disclaimers often are, it's a little wordy and some legalese, but the point is this: that last line is really the takeaway. We're going to give you some good answers to your questions and some general advice, but by no means do we know your specific case. So take those answers, take that general advice back to your home team, which does make the best plan and path forward for you. Because as we all know, each case of this disease is unique, and therefore each plan and path moving forward is as well. Okay, so I'm very excited about our guest today, who joined us even though power outages were happening yesterday in her world. She made room for us to come back today because she says, and I quote, she has to be there for her people. And I love that, because that is a sentiment that's shared by almost everybody that I've worked with in the NET community. So I'd like to welcome Alia Bauer to the show. Welcome. How are you, Alia?
I'm doing well. Thank you so much, everyone, for joining today. I so deeply apologize for having to reschedule, but I just really want to thank the staff, Rain, and your whole team for being so accommodating and reorganizing so that I could be here. I will just introduce myself briefly, if that's okay.
Yeah, please.
So I'm Alia Bauer. I'm the oral chemo pharmacist at the Sunnybrook Odette Cancer Center, and I work with the Susan Leslie neuroendocrine team at the Odette Cancer Center in Toronto, Ontario, Canada. So I'm a pharmacist that doesn't explicitly or solely deal with neuroendocrine treatment patients, but it's a lot of what I do. I will preface it with the fact that I've been on maternity leave for 10 months.
Must be nice.
Yeah.
Here in the States, we don't quite get there.
But I definitely, my brain is sort of tuned into some other types of things right now. But I did my homework last night, and I'm hoping to answer all of your questions as best as possible. But do know that I'm 10 months rusty, so it might take me a minute. But I'm so excited to be here and excited to answer your questions and ask you questions, because no one knows the journey better than patients. And so without further ado, here we go. I will just sort of maybe talk about sort of what my scope of expertise is.
I think because this is a unique episode and you're a unique guest, let's do that. Let's lay a little bit of foundation about, because really the benefit of the show is this interactive one-on-one session. So I think that's a great place to start, is letting people know like where they're going to get the most value from your knowledge specifically.
Right. So let's start with, what do I do? Like, what does a pharmacist in the NETS clinic even do? Because you might not have interacted with a pharmacist specifically in the clinic. Maybe you have a pharmacist that you work with sort of at a community pharmacy, or at a retail pharmacy, or maybe with your family physician. So what is it that I do? My role in the neuroendocrine clinic is really sort of my bread and butter, is to help patients who are on oral drugs to treat their neuroendocrine cancer sort of through that journey. So people are taking oral drugs, things like sunitinib, everolimus, to name just a couple, at home. And so how do we make that journey as safe as possible? How do we make sure that they're still connected to the team and able to report in side effects? They're able to access that treatment, talk about their side effects, talk about how they're feeling, talk about, if they're having any trouble taking the actual medication, but they don't actually have to come to the clinic to do all that. They still have to come sometimes, but they don't have to come all the time. And so my whole job is to remotely manage these patients. So we do Zoom. Zoom interactions, phone interactions. We get their blood work done in the community so that they don't have to come to the center. So really my bread and butter and the bulk of my expertise is in oral drugs used to treat cancer. That being said, I'm still a pharmacist, and one of my other roles is really when patients are first, seen in our clinic and we decide that they're going to start on treatment X. One of my roles is to sort of look at their medications and think about A, will there be any drug interactions? B, what can we get rid of? So as many of you know, sometimes you see multiple different providers before sort of getting the diagnosis of neuroendocrine cancer, or maybe you had a diagnosis, but a lot of different things were tried for symptom management and they didn't work, or they weren't completely effective. And so what can we get rid of so that we don't have what we call a prescribing cascade, where we start one medication, which offers a side effect, and we start another medication to treat that side effect. And lo and behold, a few months later or years later, you're on 10 different drugs for 10 different things that weren't really the problem to begin with. So we talked about managing patients on oral drugs. We talked about sort of looking at their medications and think about what can we get rid of. And then the third thing is drug access. So a big part of my role, which is sort of a huge sort of issue in Ontario, Canada, is things around access. And so many of you might have engaged with your pharmacist to think about how you can access particular medications, whether it be through your insurance, whether it be through different compassionate drug programs that are available. So a large part of what I do is access, because I can't follow people on their medications if they can't start them. And so timely drug access is a big part of what I do. And I have a degree in quality improvement. And so one of my quality metrics is time to treatment access. So I want that to be no longer than 7 days. It shouldn't take anyone longer than a week to get access to a medication that they need for their cancer. I'll talk about just a fourth thing, which is sort of peripheral, but I think will be really, will resonate maybe with this audience, is a lot of what we're doing now is shared care. So, we might be seen at a center of excellence, which is the Susan Leslie Clinic, sort of an academic center of excellence for NETs. But then the care, once a plan is made and that plan is put into action, the care might be monitored by someone closer to home. So a neuroendocrine physician closer to home. And some of my role might be in sort of bridging that gap. So make sure that their access goes with them, that the physician who's taking over their care while they're on everolimus is sort of up to date on what's been sort of going on with the patient in terms of their side effects with everolimus, sort of bridge that gap to make a seamless transition. And that also includes patients who want to engage in integrative medicine. So, we're sort of in an era where there's so much information out there, and lots of people want to do everything that they can to help manage their symptoms and their cancer journey. And so one of those things might be to see a naturopath, or to engage in purchasing different types of natural health products. I'm by no means a naturopath or an expert in natural medicines, but I think what a pharmacist can really help with is making sure that there's no interaction. So nothing that you're taking can A, interfere with your cancer treatment, or B, make any symptoms worse inadvertently. The intention might have been very, positive, but inadvertently, has, interfered with serotonin levels, or, caused more diarrhea, just because that's sort of the nature of this world, right? Where you're on different medications that all sort of can interact and work together, both positively and negatively. So with that said, that's sort of my area of expertise. So medications. And I work closely with the team. So I'm really lucky in that I have a lot of experts around me to help guide me. And hopefully I help guide them as well. So with that said, I'm very open to taking any questions and, seeing where this takes us.
Awesome. Well, folks, I think that that does a great job of kind of establishing really the value that you'll get here today. Again, this show will live. It'll be evergreen on the videos tab here on the Facebook page. And starting Monday, we will put it on YouTube. So you can always access this. You can always replay this. Someone else can always access this. But really, the benefit is the interactive session. So let's try to get as many people here as possible to answer some of these questions. I know you all have medication questions because we get them every week. This is the episode for you. So anyone else that you think would benefit from this, another patient, a caregiver, anyone else, go ahead and tag them in the comments. Let them know the show's going on. You can share this to their page, text them, email them, whatever you need to do. Call them, tell them to get here. And another thing I'll ask you to do, which you do every week very well, and so I'll continue to ask because it helps me do my job. If you see a question in the sidebar there that someone has, Alia, you can't see those, but I can. If you see a question that you also want the answer to, or you're interested in, you can right below the question, there's a where it says like and it says reply. And you can hover over that like button. It actually gives you several different kinds of emojis you can use. They all worked effectively the same way for me, which is to upvote it. It allows me to know there's a demand for it. We get so many questions that often we don't get to them all. This lets me know there's a demand for that question, and I will get that across. So go ahead and start sending in those questions. I see they're starting to come in. We have a lot of people from Canada every week, I'll say, that are showing up. And we also have our friend Benta from Nigeria. Hello, Benta. How are you? So people all over the world tune in live, and then by the time tomorrow rolls around, it has usually thousands of views. So we appreciate you all being here. We're going to go ahead and start asking some questions soon. I have one to go ahead and start us off. Let's lay a little bit of groundwork for people, because a lot of the people, as you'll probably learn in today's show, are very well educated about this disease. Yes. They know that being their own best advocate is of the utmost importance. And so they do their homework. So some of the questions you get will be really thought-provoking. But also some people it's their first time finding the show. They're very early into this journey. And so I always like to make sure that we lay some groundwork for those folks. So you mentioned oral medications as kind of your specialty. Let's talk about oral medications in the realm of neuroendocrine tumors. Let's just, basics, right? 101. What are the options for oral medication or medication in general for this disease?
Yeah, so let's talk a little bit about some of the treatment options, sort of broad strokes to start, and then we'll sort of narrow in.
That's perfect.
So sort of the crux of treatment, and probably the treatment that the sort of most number of patients are on, are something called somatostatin analogues.
Mm-hmm.
And so that's medications like octreotide or lanreotide. And then sort of later, typically when patients, I typically see them, is when they're starting oral treatment. So there's oral chemotherapy, so temozolomide and capecitabine, often used together, particularly for pancreatic neuroendocrine tumors. And then there's what we call tyrosine kinase inhibitors, so things like, and which is where a bulk of really sexy new treatment options are available. So some of the oldies but goodies are sunitinib, and that's sort of been the approved classic drug that we've been using as a tyrosine kinase inhibitor for pancreatic neuroendocrine tumors. But we have some other sort of new kids on the block, new to NETs, but maybe not new to other disease sites. So drugs like surofatinib is a new one. Drugs like axitinib, which we've been using in renal cell carcinoma for some time, and now we have data that was reported at ESMO for neuroendocrine tumors. Pazopanib, another drug used in renal cell carcinoma that we now have data for in neuroendocrine tumors. Lenvatinib, which is one of my favorites, and cabozantinib. And then we also have another class of oral drugs called mTOR inhibitors. Really, there's only one drug in that class, which is called everolimus. And that's, what's interesting about everolimus is it's sort of used across the board for multiple different types of neuroendocrine tumors. So it can be used for pancreatic neuroendocrine tumors. It can be used for small bowel, for lung. So it really sort of spans the breadth of type of neuroendocrine cancer. And in fact, some of our tyrosine kinase inhibitors, while we traditionally thought of them as just for pancreatic NET, now with some of the new kids on the block, we can use them for other kinds of NETs. For example, lenvatinib can be used in small bowel and lung. Okay. So that it's really great to start to see some of these other types of neuroendocrine cancer, lung primarily, start to have some more treatment options, some more tools in our toolbox, because we were sort of really limited before. But it's nice to sort of see options open up for all types of patients. I know I'm gonna get, I don't know if I'm going to, but I may get some questions regarding PRRT.
I'm sure you will.
At our center specifically, that's sort of almost exclusively handled by one of our radiation oncologists in conjunction with nuclear medicine. At least 10 months ago, it then became approved, like an approved treatment in Canada. And so things have changed. So I don't routinely care for patients on PRRT,
okay,
although I am familiar with some of the pre-medications and things that we do to support patients on treatment.
And you said that just got approved 10 months ago?
So it was approved just prior to me leaving on maternity leave. And we were just sort of in Canada, at least in Ontario, logistically figuring out, well, now that this is an approved treatment, how do we give access to patients?
Yeah.
Because, that's sort of the beauty of oral drugs, which is my area of expertise, is that it's pretty easy to give. It's not easy to take, right? Patients can tell us that it's not an easy journey. There's side effects, but it's pretty easy to prescribe and give, right? It's a pill, you take it at home. The challenge with PRRT is really logistics. And, our center was no exception. Think about, how do we make sure these patients have access to a private room?
Yeah.
How do we engage patients in understanding the safety risks and, the protocols? How do we make sure staff are safe? How do we make sure that we can get the amino acid solution in? And so all of those logistics for something that's not paid for by a clinical trial, that sort of, we as a center, as a community need to figure out how to do to make sure patients have access, was really something that a lot of thought went into. And I'll sort of give a lot of credit to my mentor and the medical oncologist that I work with, Dr. Salman Singh, who really sort of provincially spearheaded and led a lot of that effort. So, I'd love to hear from the community out there, sort of, those of you who are or have looked into PRRT, sort of what the logistical challenges or what the access issue might look like where you are.
Absolutely. And Dr. Singh has been on the show before. He's a friend of the foundation. He's awesome. And I just know, now I've been working with CCF long enough to have seen some of these leaps forward that we've made in terms of treatment. And so I remember when PRRT was approved here in the States to early 2018, it was, such a game changer, because then so many of the patients, we're having to go to Europe and overseas to get treatment. So hopefully it's having the same kind of impact there in Canada. I did have a question from Gwendolyn, who, just as I was saying, some of these people were new. She's chimed in. I am new to this. And Gwendolyn asks, are there home medications available in the US? So we just kind of touched base on that, Gwendolyn. But I wanted to give you the chance, like, if you have any follow-up questions, if that didn't answer your question, some of the oral medications that Alia just mentioned, if that didn't answer your question, please chime back in. I want to say welcome. We're here for you and appreciate you joining the show today. And any questions that you have, go ahead and let us know. But I thought that her previous answer might have answered your question. If not, just let me know. We'll be here. Next question from Karen. Karen says, what are the least toxic or what's the least toxic treatment to use while taking supplements? And she doesn't really specify what supplements. So I'm not sure if you would need that. Any more information to try to take a stab at that question?
So in general, when you're taking supplements, in general, and sort of, like you said, I don't know what supplements specifically, but broad strokes in general, sort of the least interfering treatment are things that are not oral or not intravenous. So your SSAs, your somatostatin analogues. I would still say do review with your pharmacist or your healthcare team what you're taking to make sure that there aren't any interactions, but more importantly, that the natural health products, while so well intended, because I understand and I empathize with wanting to do everything you can to stay well, stay motivated, stay healthy, and treat your symptoms or your cancer, is just to make sure that we're not inadvertently causing symptoms. So a lot of natural health products can cause things like diarrhea, can cause things like biochemical shifts in hormone. And so just to make sure that the products that you're taking aren't going to do that, and B, just to make sure that, although unlikely, that there aren't any interactions with your somatostatin analogues. But in general, that's sort of the treatment we worry least about in terms of interfering with any supplements.
Got it. Folks, if you joined us later or just joining us, this is Luncheon with the Experts at Carcinoid Cancer Foundation. We're here with Alia Thawer today, and we're talking about all things pharmacy and medication for neuroendocrine tumors, which I know you all have a lot of questions about. We get them every week, so welcome, everybody. Lori says, hello from soon-to-be snowy Maine. Lori, let me tell you something. I'm in North Carolina, and I was taking my baby to daycare this morning, and I put on my jacket, my little winter hat and everything, and it's 70 degrees outside. What is happening? It's almost Christmas. That's not cool. All right, next question from Effie. Are you familiar with a medication that might inadvertently lower serotonin to below the norm, causing negative side effects? And a few other people have this question.
So, sorry, just to make sure I understand the question. So a medication that might inadvertently lower serotonin levels.
Yes.
To too low.
Yes, precisely. Okay. To below the norm, causing negative side effects. Correct.
Okay. So, well, so there's two types of answers to this question. So I'll take sort of drugs used in the community, which don't typically apply here, but I just want to sort of make a plug. There aren't any drugs that I can think of off the top of my head. And again, I'm very specialized. So off the top of my head that sort of are routinely prescribed in the community that might inadvertently lower serotonin and cause negative side effects. However, we are starting to use a drug called Telophosphate. And I didn't speak to that in sort of my plug on oral medications because it isn't, truly an oral anti-cancer drug. It's really a drug used to treat symptoms of serotonin excess, which is predominantly diarrhea. So it's used to treat carcinoid diarrhea, and its whole role is to sort of stop the production of serotonin. And it really is focused on our gut. But what we did see in one of the trials, and in sort of larger reviews, hasn't quite panned out, but we still are mindful that this can happen, is in 6% of patients in one of the trials, patients experienced signs and symptoms of depression. And that's because it lowered serotonin in our gut, but for some people it can lower serotonin in our brain. It's pretty specific to the gut, but for whatever reason, for some patients, it might lower serotonin in the brain. And serotonin in the brain is really important for our mood. So that's why a lot of the drugs used to treat depression, their main goal is to raise the level of serotonin in our brain to sort of help us have a positive feeling, positive mood. So for any patient on Telophosphate who is having carcinoid-related diarrhea, where we're trying to lower the episodes of diarrhea on a daily basis, one of the questions we always ask these patients is, are you having any changes related to your mood? Are things that you found enjoyable in the past not enjoyable anymore? Because we want to make sure that at least, we're doing our due diligence to make sure that we're not causing a reduction in serotonin in the brain, leading to things like a negative mood or not enjoying things that you used to enjoy, because, we don't want to, like I said before, cause a new problem while we're trying to solve an old problem. I hope that answers your question.
Yeah, I think that I hope that it does too. But Effie, just remember, if you're still here, let us know if you have any follow-up questions. We will continue on, but if you have them, put them in the sidebar. Next question from Jim. Jim says, I'm currently on lanreotide injections every 28 days. The pharmacy is always very clear when I go in to pick up the injections that it must remain refrigerated. I have an RN come to my home to do the injections, and she advises that it's best to take the injection out of the fridge about 30 minutes before she arrives, as it's better for the injection process for me. Is there a risk in doing this? She has a number of patients receiving lanreotide injections, but this always concerns me. I don't want to risk impacting the effectiveness just for comfort.
Jim, that is a great question, and something I get asked a lot as well. And I think your nurse, I think that is a very wise recommendation. It will not impact the efficacy of your drug by taking it out of the fridge for 30 minutes. It is actually pretty stable at room temperature for a few hours. And so I would not worry about impacting the efficacy of how well your lanreotide is working. In fact, part of the clinical trial protocols was to make sure that the injection was brought to room temperature prior to injecting it into a patient. So the data that we have from the clinical trials that show that lanreotide work follow the same process as what your nurse is doing. I think it makes for a much more comfortable injection, and you're in it for the long haul, Jim. And so we want these injections to be as comfortable as possible for you. And so I think that is a wise recommendation, and I would not worry about that.
Got it. Hey, thanks, Jim. Great question. I have a question for you. You mentioned at the beginning of the program that a lot of your patients are net patients, but not all of them. Do you know, what's the percentage roughly?
So neuroendocrine work and working with neuroendocrine patients is about 40% of what I do. I do at my center see patients from different disease sites on oral drugs, but in fact, what's interesting is that a lot of the drugs are the same. So for example, I do a lot of work with patients who are have liver cancer. And so a lot of the tyrosine kinase inhibitors are the same. I work with a lot of patients with renal cell carcinoma, and a lot of those drugs are the same. So it's interesting that while the patient population is different, a lot of the drugs stay the same, which is cool because, which sort of helps develop the breadth of experience I have because I'm really familiar with these drugs. Because I don't just see them in neuroendocrine patients, I sort of see them across the spectrum of different types of diseases.
Mhm.
And I guess sort of my biggest takeaway, my biggest learning from that is whether you're taking the drug for neuroendocrine cancer or renal cell carcinoma or thyroid cancer or liver cancer, the side effects are generally pretty consistent. And so that gives me a big sort of basket of patients to learn from. So, what worked in Jim might then work for Tony. And so I can sort of take the learnings from different patients that I may see, and think about what worked for so-and-so for his nausea, and then try the same thing for Tony. It might not always work, but it's sort of nice to have that gamut of experience.
Right.
But I do want to be transparent in that I don't just deal with neuroendocrine tumor patients, which sort of makes me a pseudo expert, I would say.
No, I mean, you're not
Definitely
the
not a full
first,
expert.
the first expert on the show who partially deals with neuroendocrine tumors at all. I just wanted to kind of establish that, and I also wanted to ask, what are the unique challenges with neuroendocrine tumors versus some of the other cancers that you work with?
Yeah, that is such a great question. And I will say that there are several unique challenges, and I've really thought about this question quite a bit. The first is neuroendocrine tumor patients, their tumor biology, not all patients, so again, broad strokes. The disease course tends to be, for many of the patients that I see, a little bit more indolent. So for patients, so a lot of time is taken to really thoughtfully develop a plan and a treatment decision, because there's really, as many of you know, a need for a multidisciplinary decision. So we want several different experts to weigh in and to have a chance to review the scans, review the biology, review the patient. So in some other disease sites where, we wanted the patient on something yesterday, with neuroendocrine tumors, there's really a little bit more time for the experts to sort of all gather around and really weigh in to make sure that we're offering this patient the best treatment at the best time in their journey, making sure that everyone agrees and that the plan is shared with all the different members of the team that might, see the patient next or want to weigh in to make sure that that decision is in agreement with everyone on the team. So I would say the need for multidisciplinary involvement is ever more pronounced in the neuroendocrine tumor patient. And that is something that I would advocate for. So, for those of you out there, I think something that we can all, as patients, agree upon is, for NETs especially, you really want to have at least at treatment decision junctures or a multidisciplinary team have a look at your case and really understand and make sure that the next treatment is the right treatment at that juncture. Mm-hmm. So the need for multidisciplinary decision is the first unique challenge. I think the second unique challenge is heavy symptom burden that many of these patients face. And so that lends itself to not only just quality of life issues, but my area of academic interest is in financial toxicity. So some of the symptom burden that patients experience leads to, missed work, inability to work. So there's a lot of financial toxicity there. Many patients, and you guys know this better than me, are traveling long distances to see an expert or to be, worked up at an expert facility. So, financial toxicity associated with travel, lodging. In the era of COVID, we're getting really good at using technology. It probably spearheaded a lot of the uptake in technology that we probably could have used earlier, but there's nothing like seeing a patient in person and having that in-person multidisciplinary discussion. And so there's a lot of financial toxicity associated with that. And so I would say that that's another unique challenge. Mm-hmm. And then the third I would say is, and this is again, broad strokes, is I wouldn't say a distrust, but sort of an apprehension, because many of these patients have had to see multiple providers to get to where they are today. And so, like you said early on, many neuroendocrine tumor patients, not all, but many, are really so in tune, so plugged in. And I think that's fantastic, because no one can advocate for your care better than you. But I think so. Some of the things that as a team we have to work on is really garnering trust, because these patients have sort of been through multiple providers and perhaps haven't had all their questions or haven't received the answers that they wanted at each juncture. And so a lot of our role is sort of establishing rapport, establishing trust, making sure that we engage the patient and understanding what it is we're doing. So even just explaining, we are going to take your case back to tumor board so that as a team, we can discuss what is best. What does that mean? What does that look like? Who's talking? What are you talking about?
Right.
And so really making sure that we're, answering those questions and really involving that patient the best way we can into what's going on. Gone are the days where we sort of go into a room and huddle and sort of secretly talk about what's best and then come and offer one option. The patient needs to be involved in that discussion. I know I said last thing, but I thought about one other unique challenge.
No,
So
bring it.
I think we don't, and I think as a community, we're trying to do better at this, is really talk about the caregiver in the neuroendocrine patient. And I know that that's something that I'm actively working on every time I see a patient. Who else is involved? Who do you live with? Who might help you? Particularly in taking oral medications, you need help. Sometimes you need help. And it's nice to have a second set of eyes and ears to listen to what could happen, to help you in the day-to-day, who might be involved, who might live with you, who might know, who might see. So to really think about the caregiver, the burnout factor, but more just, what are their needs? What can we do for you to help you care for so-and-so better and to help you manage, the sort of load that you're carrying. So I think that's a unique challenge that we aren't doing the best job at yet, but strides are being made to move forward. I think one last thing that I will say to that question is, I really want to make sure that things that are offered to other patients with other types of cancer are also offered to neuroendocrine tumor patients, and that's something we need to actively work on. So something that's really, taking a front seat right now is something called geriatric assessment. So not all neuroendocrine patients are elderly, but some are 65 and over. And so there's a lot of data out there that shows that geriatric assessment, so really taking a global look at the patient. What is their functional status? What is their nutritional status? What is their medication status? Are they on lots of drugs that maybe, like I said, can be taken out or simplified? What is their cognitive status? What do their support system look like at home? So really taking a global assessment of the full patient before they start treatment has actually been shown in several populations to reduce medication errors, to reduce adverse events, and to, in some cases, decrease hospitalization, and even in some cases improve survival. And so while we don't have this hard data in neuroendocrine tumor patients, it definitely can't hurt to make sure that patients who are elderly, who are starting something particularly like cytotoxic IV treatment for your high-grade neuroendocrine tumors, are given opportunity to have a geriatric assessment to make sure that they're given that best chance to make it through this treatment, as unscathed as possible. So I think that is a unique challenge to make sure that things that we're doing for other patients, we're also doing for neuroendocrine tumor patients.
Absolutely. Yeah, no, thanks for that. And I had a question later for about multidisciplinary teams. I'm glad you touched on the importance of that. This is something that comes up every week as well. I have a question that I'm going to ask. We'll see if we can approach it, but it's somebody who really needs help, and so I want to get this across, and we'll see what kind of guidance we can give. He says, unfortunately, in my rare case, tumors came out of me, perhaps because it came out of me with stools, white masses like fat, and have roots, and then a burning pain in the flesh and bone of my body. I have a high level of serotonin in the blood and urine, and I had a nuclear picture FDG and also gallium dotatok. Nothing showed significant weight loss. What is the best picture for diagnosing the spread of serotonin producing carcinoid? Please, I am in a country where medicine is not advanced and doctors do not know what to do. So that was a lot. I'm not sure if you followed. Any thoughts about that general issue?
So there's no scan. Well, at least, so I'm going to preface it with, I'm not a diagnostic therapy specialist. I'm not a diagnostician in any way. But there's no, at least that I'm aware of, scan to show serotonin. The gallium-68 scan is the best tool that we have, at least where I live, to help us identify somatostatin receptors that might increase your propensity and make you more likely to respond to treatments like somatostatin analogues and PRRT. So really, to understand if you have high level serotonin, the test that we typically do is the urinary 5-HIA. And so that's really looking at in your urine, what levels of serotonin byproducts are coming out. So we can understand what is the total picture of excess serotonin in your body. And so that's sort of the test that is most routinely used to identify if you do have an excess level of serotonin production. There's no scan that we use to identify serotonin. It's the urinary 5-HIA test. It sounds like you have a lot going on, and I'm sorry to hear that. I would, if that sounds, like a complex picture, that I would recommend you going back to your care team to just make sure that, they've done all the assessments that are required and that you feel comfortable with that. But typically, to understand if you have an excess amount of serotonin in your body, it's a urinary 5-HIA.
Awesome. Thanks for taking a stab at that. Lisa says, what are you seeing on the immunotherapy front, and specifically she has a lung primary?
Yeah, so that is a great question, and I get a lot of these types of questions, particularly from lung neuroendocrine patients, because there is so much direct to consumer marketing for immunotherapy in patients with lung cancer. So like not a lung neuroendocrine tumor, but a lung cancer. Sure. And in that space, immunotherapy has sort of just revolutionized and just changed the treatment paradigm, and just really offered a fantastic treatment option for patients with lung cancer. So a lung primary, not a lung neuroendocrine tumor. So in patients with a lung neuroendocrine tumor, so not lung cancer, but a lung NET, we did see data that the response rates for immunotherapy were the best in patients with a lung primary, a lung neuroendocrine tumor. However, while they were the best in that population, they still weren't fantastic. It was a response rate of about 20%, which is actually no different, not horribly different than what is seen in, just regular lung cancer. It's just that the longevity of that response in regular lung cancer is very robust. It's a 20% response rate, but you can respond forever and ever almost. Like, it's just, you could have a long duration of response. The data is still in its infancy in neuroendocrine tumors. While we do know that if anyone's going to respond, at least so far, what the data tells us is that it's going to be a patient with a lung NET. Yeah. We don't have the hard outcomes to show what are the predictors of response. How do I know you with your lung NET will respond versus you with your lung NET won't? We don't know really. We don't have a good sense of how long. Like, is that response robust? If you're one of those 20% of patients, will you have a long response? Because that's really what we want. Or will it be a short-lived response? In which case, we should really explore other options. In general, for neuroendocrine tumors, we haven't seen great results for single agent immunotherapy. So one immunotherapy drug. We've seen some promising data for combination immunotherapy, but where I really see the place living for immunotherapy in both lung NETs and other types of neuroendocrine tumors is in combinations. So combining immunotherapy with chemotherapy, for example, has actually been a very successful strategy in lung cancer. So not lung neuroendocrine tumor, but lung cancer, just general lung cancer. And so that is being explored in clinical trials for neuroendocrine tumors in general, particularly lung NETs as well. So I think I've taken a long-winded approach, which is very typical of pharmacists, to answer this question. But I will say the data is in its infancy. It really is a treatment option best reserved for clinical trials, looking at how to utilize immunotherapy safely and effectively. And it is probably not ready for prime time. The only exception to that, I will say, is it is ready for prime time if you have a sort of an advanced lung cancer, what we call a small cell carcinoma, which is a type of NEC, but typically treated by lung oncologists. That is one area where it's tried, tested, and true. It has phase 3 evidence. It is the mainstay of treatment at this juncture. But for like an atypical lung NET, not the mainstay of treatment yet, but some exciting clinical trials that I think will help answer that question more fully.
Awesome. Thank you for that. I appreciate your question, Lisa. Next question from Skip, and a few people have questions about lanreotide. Skip says, why does lanreotide cause severe stomach pain just out of the blue sometimes?
Yeah, Skip, that is a great question. I'm sorry that you're having severe stomach pain. So the fact, it's really just due to the mechanism of action of the drug. So it can cause sort of contractility or some spasming. And that's just part and parcel with how the drug works. And so because it sort of works on the smooth muscle lining, it can cause some spasming or just some cramping. That's one of the unfortunate side effects of the drug. There are things that we can do to help mitigate that. So, things like buscopan to help if you're having cramping, so things that can, if the stomach pain or the cramping is associated with diarrhea or constipation, we can work on that. And things like thinking about, is there something, keeping a diary to make sure you understand the timing. Is it really around the injection? Is it that the injection is wearing off and it's really a symptom of your carcinoid, or is it the injection itself? So keeping a diary, understanding the timing, but that is just part and parcel with the mechanism of action of that drug. And it's one of the side effects that it's known to cause. And I'm sorry that that's happening to you.
Got it. Next question from Jim. Jim says, I'm in British Columbia. My primary oncologist is a chemo doctor, but not a NET specialist. My surgeon specializes in NET cancer of the liver and pancreas. And whenever there are complexities or major changes or questions in my case, it is presented in front of the BC Cancer Board. Can I be confident that there would be NET specialist on those web meetings, or should I be looking to travel further for a NET specialist? I really like my oncologist and I have faith in his level of care, and I know he does not ever hesitate to reach out to others for guidance as needed. But I do also realize that he may not always be at the leading edge of new treatments and research in the NET space. So this is a common problem.
Yeah.
And actually, Jim here, feels a little more confident than other people in either their general physician or oncologist, but he's still curious. Like, do we need a NET specialist to seek that out in this case?
So Jim, that is a great question. And I will say, so let me first go general and then go specific.
Absolutely.
So generally, when a case is presented to tumor boards, the whole premise of presenting it to tumor boards is to make sure that you're presenting it in front of the eyes of experts. So in Ontario, where I am, we have provincial tumor boards. So for centers where there might not be a NET specialist at your center in your region, your case is presented to a provincial board where experts in the province can sort of weigh in and say, I might not have seen this patient, but I'm looking at the scans. You're giving me this great description. I'm looking at the pathology. I'm understanding where this patient has been. And I can say with confidence, in conjunction with the fellow expert that I have on this panel, which might be surgery, nuclear medicine, interventional radiology for things like chemoembolization, I can confidently say, that this is my opinion, and let me sort of bounce this idea off these other experts so that the physician in British Columbia, or in my case, the physician in, small town Ontario can sort of say, well, I've presented this case to a panel of experts. I might not have had the patient go there. Maybe I have, but I might not have had the patient go there, but I can say at least someone has given me some guidance. And that's typically what happens at tumor boards. However, it's not always what happens. Sometimes the case is only presented locally. So I think the best advice I can give you, Jim, is to really ask, and don't have any qualms about asking. There are no egos in care. To really ask and say, can I ask who was present at the tumor board? Was a NET expert present? Who did you ask? Ask for a name. And then you can do your own research on that person. I will say more and more the sort of, particularly in the era of COVID, where we're becoming so savvy at using technology to make sure that there are no barriers to receiving care. Really, all of our tumor boards are on Zoom. So it makes channeling into an expert really easy. So I would say there are no egos in care. To ask who is present, to ask if there were experts present, and to really hone in on, what was discussed. Can I ask what was discussed? Because I think it's so important for you to know and to feel comfortable with the fact that, an expert has seen your case and expert eyes have been on your care. Having said that, I do want to say that an expert is not needed at every juncture in care. And so at least where I'm from, we know there are limited experts, and we really want to utilize those resources effectively. So I can put in a plug for it. It is so important, at least in my opinion, to have an expert team or a center of excellence look at your care at the time of treatment decision. So you've progressed on one treatment, or you're newly diagnosed and you want to make sort of a new plan. That is where I think a center of excellence or expert team is really important. If you're on everolimus, for example, or you're on lanreotide and you're having a side effect, I think a local oncologist is equipped to deal with that. And actually, there's data that shows that physicians at community centers are feeling confident in managing side effects, but they're not feeling so confident, at least in this survey, in managing treatment decisions, particularly around PRRT, because that's sort of a newer treatment. So I would say there are key times in your journey that you want to make sure an expert has had a look at your case. And those particular times are times of treatment decision or change in care plan. And there are no egos in care, so don't hesitate to ask, because I think that's a really valid question, Jim.
Appreciate that. Yeah, thanks, Jim. Folks, we got just a little bit more than 10 minutes today. Great questions today. And Ruby says, great information today. Glad I could watch it again. We're glad you could make it, Ruby. So I mentioned earlier that we had a couple questions about lanreotide. We have another question about pain specifically, but a different kind. Melinda says, I was switched to lanreotide 4 months ago. It is very painful to the point that I almost pass out at the time of injection. Is this pain normal while getting the shot? And someone else, Jim, I believe, had chimed in and said he had experienced the same thing. So now this isn't about like side effects, but actually the moment of the shot.
Yeah. So one thing I just would love to clarify, are you guys self-injecting, or is a nurse injecting the lanreotide?
Yeah, that's a good question. I don't see. So Jim had chimed in and said, hi, Melinda. It was quite painful for me at first too. And he laid down some steps, but a nurse prepares Jim's. But Melinda, if you want to chime in and let us know. But let's tackle that, Alia, like both ways. Would there what could they look for if they were self-injecting versus a nurse?
Yeah. So I will again go broad strokes. In most cases, one of the trained nurses from the lanreotide program tend to inject the lanreotide. And so, and we know this, a lot of times injection pain is associated with injection technique. And so it shouldn't be excruciatingly painful. And, patients know this better than me because I haven't ever received a lanreotide injection. So I think talking to your peers is a great way to understand, what is your level of pain compared to what some other people are describing. It should not be comfortable. It's not going to be comfortable injection. It is a viscous liquid. It's deep sub-Q injection. So it isn't going to be comfortable. But I will say, and we've given this injection a lot, it shouldn't be excruciatingly painful. And so if you are experiencing excruciating pain, I would go back to, if you're self-injecting, I would revisit the technique. If a nurse is injecting, revisit his or her technique. And so really think about, A, are you taking that injection out of the fridge 30 minutes before? Because that tends to be a more comfortable injection. B, is a person who's providing you with the injection someone who's really familiar and have given multiple injections in the past, because practice makes perfect, and technique is sort of perfected over time. And 3, if it truly is excruciating, of course you can take, a Tylenol or something before, but what I really might recommend is try a different nurse. We all have chemistry. We have chemistry with some people. Sometimes so-and-so's hands just work better than so-and-so's hands for you. And we're all different. We're all individuals. And again, there are no egos in care. So I would just go back to the lanreotide program and say, I'd like to try someone else. And I've recommended this multiple times. And for whatever reason, sometimes you just have better injection chemistry with one nurse over another.
That's a good point.
But I will emphasize it should not be excruciating. It should be uncomfortable. It should be tolerable. And again, you're in it for the long haul. So you should, advocate for yourself and do whatever you can to make it more comfortable. And I would say technique is where I would start.
No, thanks for that. And it seems from the way Melinda was describing it that I would probably use excruciating. She said to the point where she almost passed out. And Melinda, yeah, I know, me too. And Melinda, I'm not sure if you saw Jim's response, but he gave some great general advice about this, but I think it applies to so many other things. I just want to repeat it. He talks about laying down for an hour prior to it, and even uses a meditation app to just get himself in a calm state, which I think, I mean, that helps this. And
that's a great idea,
isn't it? And he goes on, and I just have to plus one then this to talk about really working on his breathing before the injection as the nurse is preparing it, and then really focusing on the slow, deep breathing during the injection, exhaling slowly and deeply as the injection goes in. Now, I'm not a medical expert, but I've worked in the physical fitness space for a long time, and breathing out at the point of any type of pain, helps you navigate that. So I think that's just good general advice. And also
great advice. Something I'll repeat.
Right. And to go back to what you said, Alia, part of the benefit of this show is almost half and half, is the information from experts like you, and then also the shared experiences and stories from the community themselves, as you alluded to. So I'm glad you said that, because that's so much of the helpful information also comes from their peers and people also dealing with this disease. And that's a good example of that. So thanks, Jim, and thanks, Melinda. And of course, let us know if you have any further questions. We're still here for about just shy of 10 minutes. So Kathy says, what would the next treatment be for stage 4 after using octreotide and lanreotide since 2019, but having too many side effects to continue injections? So she's kind of exhausted that, she feels.
So I would say, okay, I'm going to say two things. The first is, I'm sorry you're having side effects. And I'm sorry that they're so unbearable that you have to come off the treatment. And so the first thing I would say is, I feel like I haven't done my job if someone has to come off a treatment because of side effects, unless I can truly say that I've done everything possible with that patient to make sure that they can safely and comfortably stay on. So before we throw the baby out with the bathwater, and I'm sure you've done this, but I'm just going to make a plug for this, just to make sure that you've talked with your team to make sure that there's nothing else that can be done comfortably, because I believe that it should be comfortable to comfortably keep you on a treatment that's working, if the SSAs are working. So the next thing I will say is, the next line of treatment really depends on the type of cancer that you have. So the type of neuroendocrine tumor, and sort of what the disease biology is telling us. If you've sort of been coasting, you've sort of been doing this and nothing's really growing, observation might be okay. If you've been sort of progressing on treatment, and while you're having side effects, it also hasn't been working incredibly well, then we might start to look at other things. For example, if you're a pancreatic patient, there might be an option for some of the oral drugs that I was talking about. PRRT might be an option if you have small bowel. So I would say, take that question back to your care team to really make sure that it's honed in and specific to you. I don't want to tell you that there aren't treatment options. There are, but SSAs are typically such a well-tolerated treatment, and I'm sorry that you're having such a difficult time. But they're overarchingly, and everyone's different, but they're overarchingly generally usually the best tolerated treatment. And so just to make sure that, we've done everything we can to keep things comfortable. And if we've truly tried, and it sounds like you have, if you've truly tried and it's just truly not working, to take that back to your care team to think about what's best based on your tumor and your biology and you as a patient.
Got it. Hey, thanks, Karen. So we've had a few people chime in about the pain at the point of injection since we last chatted. Let me see what you think about this. Laura says, I put an ice pack on the injection site, and sometimes I don't feel it at all. You think that's a good strategy?
Yeah, so an ice pack can work. From what I've learned from the injection nurses, so this would be a great question for an injection nurse as well, is so just to be careful, because sometimes what they say is sometimes an ice pack at the site of injection sort of slows the release of medication into the system. It doesn't mean that it won't get there. It just might slow the release. I have no problem with it. I think if it works, that's great. Medicinally, I don't see a problem with it from a medication working standpoint. It really just it's really just a numbing agent, right? To numb the area. Another thing that you might want to consider is Amla cream, which is it's a medicinal numbing agent. There's a patch and a cream. It really just numbs the injection site area. So if it's truly not technique, if you've tried different things to help mitigate the pain, some of the strategies that Jim talked about, an ice pack, which is essentially the same thing, a numbing, a way to sort of numb the area. Then Amla cream or a patch might be a good way to sort of get through that injection. It's pretty benign. You just apply some at the area, do the injection, and then off you go. But I think an ice pack is, a pretty low tech solution to what sounds like a common problem. So I think that's a great place to start. I think if an ice pack, Amla cream doesn't work, thinking about, what other strategies. So for example, looking at, perhaps technique.
Yeah.
But like it shouldn't be excruciating. And so if some of these strategies aren't working, do revisit technique and chemistry, because I want the injection to be tolerable.
Absolutely. Earlier in the program, we spoke with Karen about supplements, if you remember that question. So she has a follow-up question that says, well, what are your feelings on high doses of vitamin C infusions?
Yeah, I mean, so I actually get asked this question a lot from all types of cancer patients, not just neuroendocrine. And so there is really no data, to the best of my knowledge, that high doses of vitamin C work. They can interfere with other, vitamin C is a heavy antioxidant. They can interfere with treatments, particularly intravenous chemotherapy. They can also interfere with some types of oral chemotherapy. So I would say temozolomide would be one of them. So I would say, I think, and this is just me as someone who, with an opinion, and, you can take it for what it is, and I'm not expecting everyone to agree with me, and I'm by no means a naturopath, but I would say I would not invest time and money in high dose vitamin C infusions. Do I think they work? I don't. Do I think they're costly? I do. Do I think that natural medicine, is not something I would do? That's not necessarily true. I think patients should do whatever it is that makes them feel like they're doing the best they can to manage their disease and their symptoms. And so I'm not saying all types of natural medicine, or I'm not disregarding natural medicine in total. I'm just saying if you're going to invest in something and you're going to take something forward that, is a plan made by our naturopath, for me, it wouldn't be high dose vitamin C infusions.
Got it. Hey, Karen, I appreciate your questions today, and hopefully that helped. Well, Laura had a quick question about the cream. Can you buy that cream over the counter?
Hi, Laura. Where I am, yes, you can.
Okay.
I don't know, every jurisdiction and region is different. So it would be something that I would talk to your doctor about, or your nurse, because, and I've used it for a variety of different injections. So for example, in breast cancer, there's lots of intramuscular injections. In prostate cancer, there's lots of intramuscular injections or deep sub-Q injections like lanreotide. And EMLA is something that we commonly use to make it a little bit more tolerable.
And that's EMLA?
You got it.
Yeah. Okay. And so Laura, if you look just under your comment, we responded back to you with a link with some more information that you can find that. So hopefully you can access that and find that cream easily. Alia, we've just got about a minute or two left. I wanted to ask you, we talked briefly about some of the leaps and bounds we've made in the past 10 years. Things that you're excited about in the next couple of years coming down the pipeline, medications, treatments that about that could really, help us in treating this disease?
Yeah, so there's a few.
Great.
Sort of the first one, just because it's what I do,
yeah,
is a drug called Lenvatinib. Really any of the new TKI. So I guess what's really crucial is that we now have more tyrosine kinase inhibitors. So we don't just have one suitant, we have a multitude. Lenvatinib is the one I'm most excited about because it in a clinical trial, phase 2, though not randomized, meaning, there is an opportunity for bias, but what the trial showed us is that it had a really high response rate, higher than we've ever seen with an oral pill for cancer. So I think that is one drug that I'm really excited about. It is a tough drug. It is a tough drug to get through for patients. I would start at lower doses than used in trials, but that's one that I feel is promising, is ready, is at least something that we're already using in the clinic, and something that I'm excited about because, again, it's not just a drug for pancreatic neuroendocrine patients. It's a drug for small bowel and other types of patients. And I think we needed that. We needed some options for patients who weren't pancreatic net. The second, and again, same goes for cabozantinib, which I'm really excited about to be another oral treatment option. And I'm particularly excited about cabozantinib in lung neuroendocrine patients, because again, that was an area where we didn't have a lot to offer patients. I'm really excited about how to best use immunotherapy, and we have some trials coming out looking at combination immunotherapy with chemotherapy, and I'm excited to see what those results might show. We've had such success combining immunotherapy with chemotherapy in other disease sites. So I'm really looking forward to see what that might show. Thirdly, while this is not my area of expertise, PRRT, I'm really looking forward to some of the clinical trials to help us understand what the best way to use PRRT is. The first question is treatment sequence. So we know PRRT should generally not be the first treatment offered, and it should generally not be the last treatment offered, because by then, people are sick and it's logistically challenging and you might not get the biggest bang for your buck. But what is the best sequence of treatments? Is it PRRT second? Is it some of these other drugs second and then PRRT third? So really answering some of the sequencing questions I think would be really helpful. And then just what are the best ways to use PRRT? How can we make it more directed? Maybe it's combination, maybe we can think about, even making it more directed. Predictors, who will respond versus who will not. You can take 2 small bowel patients and one might respond with great tumor shrinkage and one might get stable disease. Why? What is different about these 2 patients, about their biology? So predictors of success, using PRRT better in the right space at the right time in the right patient. I think answering those questions would be really helpful. So those are the areas of study that I'm most excited about moving forward.
Awesome. Thank you so much for sharing that. Well, folks, that's our show today. It is the hour and it is up. Jim says, amazing session today. Thank you so much for your time and insights. That goes to you, Alia. So thank you so much for being here. I appreciate you making time for us, even though with all the issues you were dealing with yesterday. We're so glad we were able to do the show because this is our final one of the year. So thank you so much for being here.
Well, thank you for having me. I don't know if you've had other pharmacists on the show, but I'm really thrilled. And I actually learned a lot from you guys about particularly the injection site reaction. So thank you for that.
Oh, that's awesome to hear. And folks at home, thanks as always to you. And we hope this program helped answer some of your questions. I'll reiterate, if you have follow-up questions or we didn't get to your question, reach out to Carcinoid Cancer Foundation, either here at their Facebook page. You can send them a private message, or you can visit their website at carcinoid.org. Thanks again, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. Finally, folks, my name is Rain Bennett. I am your host. Thank you for watching. This is our final show of the year. We're going to take just a couple of weeks off. We'll be back in January, whatever the Thursday is. I think that's January 6th, I believe. And so that we hope you join us then. So join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.